What's up, guys? I have a very exciting video today. Fluids in the ICU. For the basics of fluid shifts, you want to recall that the total body water is about 60% of a person's body weight. And the total body water is made up of two components, the extracellular fluid and the intracellular fluid. The extracellular fluid is made up of the blood plasma volume and the interstitial fluid volume. The plasma volume in a normal body weight would be around 3 to 3.5 liters, and the interstitial fluid volume is 11 to 13, while the intracellular is 27 to 30 liters. The way I remember crystalloid fluids is that I like to think that they have little crystals of electrolytes to help me remember that they have electrolyte solutions with small molecules that can freely diffuse across from the intravascular compartments to the interstitial compartment. The main composition of crystalloid fluids is sodium chloride. And sodium, remember, determines the volume of the extracellular volume, and it distributes all across the extracellular compartment. And the plasma volume makes up 1/4, or 25% of the interstitial fluid volume. And only 25% of crystalloid fluid will expand the plasma volume, while 75% will expand the interstitial volume. So recall that crystalloid fluids primarily expand the interstitial fluid volume, not the plasma volume. The first crystalloid we will be discussing is isotonic saline. It's hypernatremic, hyperchloremic, has an elevated osmolality and a lower pH when you compare it to our own plasma fluid. And I created this chart here, and I also created this image, so you're going to see it a lot during this video. So when you compare it to our own plasma, it has 154 milliequivalents compared to plasma's 140, and it has a larger chloride concentration of 254 when you compare it to plasma's 103, and it's hyperosmolar compared to physiologic osmolality. So if you give 1 liter, you're going to have 275 milliliters are going to go to the plasma, while 825 milliliters are going to go to the interstitial volume. And that's actually more than 1 liter if you add those up, and that's because you actually pull some of the cellular fluid will go into the interstitial fluid as well. And you want to be careful in using in heart failure patients too, because remember they are already volume overloaded, and there's a lot of volume in the interstitial fluid to begin with in heart failure patients, right? And you also want to caution because it can cause acid-base shifts, hyperchloremic acidosis, and it can also cause kidney injury. Next up for the crystalloids is lactated Ringer solution, which was formerly known as Hartmann's solution, and it has less, as you can see in the table here, it has less milliequivalents of sodium. Despite having lactate in the solution, it does not seem to affect blood lactate levels unless given in very large volumes during infusions. Trending lactate in septic patients with concomitant fluid resuscitation with lactated ringers is appropriate therapy. You just trend the lactate levels from a site other than the catheter site that's used to infuse the LR solution, because the lactate levels at the infusion site will be elevated. So you will see that there is 4 milliequivalents of potassium in 1 liter of lactated Ringer, and many people think, oh, this is going to cause hyperkalemia. However, this is like such a small amount over an entire bat, like 1 liter, a whole solution. So it's not going to change a person's potassium levels. That's a misnomer. And if you want to learn more about lactated Ringers versus normal saline, you can watch my video on the Salt Ed trial, or you can read more about it. I'm going to link both of those things in the description for your viewing. But just to recap, lactated Ringers, when you compare it to plasma and normal saline or isotonic saline, it's got 130 milliequivalents of sodium, 109 of chloride, 4 of potassium, and 3 milliequivalents of calcium, with a closer to physiologic osmolality when you compare to normal saline. And we also have hypertonic saline. It's a solution, for example, 7.5 sodium chloride. It does an excellent job at expanding the extracellular volume, so much that the effect of the volume expansion is 8 to 9 times greater than isotonic saline. There is some literature that supports the use of hypertonic saline solutions for pre-hospital resuscitation in trauma patients. However, there is no survival benefit at this juncture in time. This is not a go-to fluid for resuscitation efforts, and not commonly used in the ICU in terms of volume resuscitation. Both Normosol and PlasmaLyte contain magnesium acetate and gluconate without calcium in their solutions. Both of these solutions have a pH of 7.4, and specifically in blood transfusions, you'll see these two used as diluents for red blood cell transfusions. Although not often used compared to normal saline and lactated ringers, you rarely see interstitial edema with these compared to normal saline. So dextrose is not a crystalloid nor a colloid, but I did want to include it because we sometimes add it to different fluids. So adding dextrose in general to different fluids is going to increase the osmolality. And you want to recall that dextrose it's often rapidly taken up by the cells and metabolized. So the elevation in the osmolality quickly decreases. And because the cells in the body primarily pick up the dextrose, the primary effect of D5W is an increase in the intracellular volume, or in simpler terms, it causes cellular swelling. Consequently, if you add D5W to something like normal saline, where the osmolality is already high, you will see an even larger effect of water leaving the intracellular compartment and shifting to the extracellular compartment, increasing the volume. And if the ability to process glucose is impaired and the patient is receiving D5W, this can actually create a very dehydrated intracellular compartment, leaving the cells very, very dehydrated. In very ill patients, so arguably almost everyone in the ICU, right, they're shunting their pyruvate to lactate instead of regular glucose metabolism due to hypoperfusion throughout the body. So when you go back to the basic biochem, if we're loading all the D5W, then we're actually contributing to the production of lactic acid formation, which, another adverse effect is also loading with D5W can also cause hyperglycemia as well, and that's pretty straightforward. You want to recall that the mortality and morbidity benefits to keeping the blood glucose levels between 140 and 180 in the ICU. So we don't use this too often in resuscitation, and that's pretty much it. Okay, so colloids, the basics of these guys, basically they carry large solute molecules, and those do not readily pass from the plasma to the interstitial fluid. And because they're so large, they generate an osmotic force known as oncotic pressure, or this is synonymous with colloid osmotic pressure. These two are synonyms, okay? So if I use one during this time, you can interchange it for the other one. The rate of fluid exchange between the capillary bed and interstitial fluid depends on the hydrostatic pressure and the colloid osmotic pressure. And at rest, our bodies prefer to have adequate plasma volume, so the net force favors colloid osmotic pressures to be greater than that of the hydrostatic pressures to pump up the plasma volume. A large contribution of the plasma colloid osmotic pressure is made up of albumin in the plasma. So when you have a patient who has hypoalbuminemia, it makes sense why they have swelling. The hydrostatic pressure is greater than the colloid osmotic pressure, and there's a shift of fluid into the interstitial compartment, expanding the interstitial volume, leading to interstitial edema. On the contrary, when using things like 5% albumin, which has a colloid oncotic pressure of 20 millimeters of mercury, or 25% albumin, which has a colloid osmotic pressure of 70 millimeters of mercury, the net change will result in increasing the plasma volume. Albumin, heterostarch, and dextran are all colloids, and in ascending order, 5% albumin to 25% albumin have successfully larger and larger oncotic pressures and thus greater and greater effects on the plasma volume. In general, hyper-oncotonic solutions are known to cause kidney injury, and although at this time the mechanism is not clear, heterostarch and dextran also in particular inhibit von Willebrand factor and can lead to bleeding. And another thing about dextrans is we don't normally use them, but something else is that they can interfere with red blood cell cross-matching. So transfusions in the presence of use of dextran, you need to have wash cells for transfusion preparations. So just, in summation, there's a constant battle as pretty much as old as the age of time, it seems, between crystalloids and colloids for hypovolemia resuscitation. The literature's ongoing, and some physicians, they'll swear by one versus the other. Each type of hypovolemia is treated differently, and with that, that's all I leave you with for now. Please reach out with any comments or questions. I'll do my best to answer. And otherwise, I had a lot of fun making this video, and thank you all for your time.